All right, so I just wanted to open up, again, thank everybody for coming and participating and eating. Please eat the food. I just wanted to open up the question and answer session to see if anybody had any questions for the speakers that are here. If you have questions for Dr. Misdraji, you can relay them to us and we can get them to him, or you can email him. He, who is also one of the directors of the PMP Research Foundation, and she works with Jim and her husband Jerry Lewandowski, and they, again, I just want to thank you guys again for helping and sponsoring this symposium and allowing everybody to come together and share this information and fellowship as well. So Carolyn's going to run the question and answer session for us. And
I'll just give you guys a quick introduction, especially since we've had some great survivor stories here. I'm really here in place of my husband. He's the president of the PMP Research Foundation. I guess I'm technically the general counsel, but kind of more of a do whatever needs to be done kind of a person. But he was diagnosed 7 years ago next week, the day after Thanksgiving. And at the time, we were just about to get engaged. And since then, he had a HIPEC. We got married. He had a second HIPEC, did a year of chemo, had a third HIPEC, and by the third HIPEC, I was pregnant with our first child. And he has been, he will have been disease-free 5 years come March, and now we have another child, and so there is hope. So just wanted to get that story out there. And obviously, that's a big part of the reason why we do this, and we're so glad that all of you are here. And with that, I'm going to now let you guys talk. So how we're going to do this, if you have a question, stand up and ask it. I'm going to relay it into the mic so it gets picked up by the video, and then our speakers will answer in their handheld mics. So raise your hand, and I will call on you. Go ahead.
I asked Dr. Lambert this question, but I don't think there was an answer. So I don't know if there is an answer now. If I drink wine, am I increasing my chances of recurrence?
So the question is, does drinking wine increase chances of recurrence?
I might actually defer that to Dr. Sullivan.
It's one of the things. Is this on? The AICR in their guidelines do not say that we cannot drink alcohol. The recommendation is for no more than 1 glass of wine for women. I don't know why we get shortchanged. Actually, I do. It has to do with hormones. And 2 for men. Per day, or per week, or per month? Well, if you're really pushing it, they are saying, you know, they say the guidelines say per day. They recommend that you be careful about that. And of the 2, red is better because of resveratrol and things like that, except that, you know, there are many people that can't do the taramine in red wine gives them headaches and whatever. So, you know, but then if we're talking wine is better according to, but alcoholic drinks, it's 1 ounce of alcohol. So that would be, you know, so martinis I think do not fit that. I don't make them, but I think there's two, right? Aren't there 2 shots in a martini?
Why are you looking
Who
at me?
make? I don't know. Because you're the guy and most men are the bartenders.
I've heard that there is an association between alcohol and breast cancer.
So the follow-up was the association between alcohol and breast cancer.
Yes, there is. They've lifted, again, I am not an expert in all of this. This is just all the literature that I go through. The guidelines that I have just given you are the ones given out by the AICR. They look at, I know there was a period of time, and I would defer to my medical colleague here, but breast cancer patients were advised not to drink even wine, but I know that they're now told that they can also have. Yes, Brett?
So I think, let me answer this kind of in 2 parts. And I think it's a little difficult for us or for cancer survivors to kind of differentiate between the 2. So what I can confidently say, or how do I put it? You have to think of yourself, there's something called primary prevention. So if you've never had a cancer ever before in your life, there's large population studies. So there's the physician health study or the nurses health study where they have 50 or 60,000 people, and they question them about how many alcoholic drinks they had a day, and what they found is that in large, huge populations, the people that had slightly more alcohol had a slightly increased risk of developing breast cancer. So that's in everybody who's never had cancer. Once you've had cancer, that's a different question. So what you're asking, I think you're asking, is once I've had cancer, will alcohol increase the risk of my cancer coming back? And the answer is that is a much murkier question, because this is already a rare disease. So we're not entirely sure what causes this disease to happen the first time, no less your disease coming back. So I think it's a much murkier question. I think that I'm a very like, as you can see from my presentation, I like to think of things very simplistically. You can make things very technically complicated or think of them very simplistically. I really like Mary's graph with a U-shaped graph, and that graph works very well for almost every single type of supplement. And it's amazing, is that, so you guys can remember selenium was about 5-10 years ago, or before that it was vitamin D, and then before that it was calcium, and there's vitamin A, and every couple of years somebody says, you know what, we found that people who have low of this, they get more cancer, so thus, if this is good, then let's do more. And almost undoubtedly, with every single study, when they do that, they find that extra doses of it don't help and probably hurt. So I think that U-shaped graph is a very good way to live your life. Just everything in moderation. You know, I think that's a good, nice, simple recommendation, is that I can't guarantee you it's going to not make a difference. On the flip side is that if you're drinking, you know, 2 bottles of wine a night, it's probably not going to help your liver forget your cancer. So I would say, you know, probably a good rule of thumb is moderation is the key. And as you're trying to read through the literature, or as you're trying to look at, you know, because every night on the night news, they give you a new little fun fact. You have to kind of figure out where that fact is coming from. Is that a population-based study, or does that have to do with cancer recurrence? And those are two different questions. So it's pretty clear in population-based studies, certain things can increase your risk. It's usually at extreme doses, you know, that on the end of that U-shape. But it's a lot less clear for people who have cancer. Is there something that can predict your risk of coming back? That's a lot less clear. It's probably more has to do with the genetics and the pathology than it does anything you put in your body. That's a long answer, I'm sorry.
The only thing I want to add to that, though, is you have to remember the things that turn into carcinogens, you know, and also you don't want to keep a state of inflammation in your body. And so that's the kinds of trouble that people can get into even with moderation. You know, if all you have is the wine and nothing, you know, to help it, or the alcohol, then that can act in a negative way.
So you're saying drink lots of fluids?
Other than wine? No, even, you know, you can, drinking, anyone that I've cared for in the post-op period here would know that, you know, one of the other problems people get into, you have to be in a sick state. But, you know, I have people that get into problems all the time with just water. You know, if you are already sick and you've got an electrolyte imbalance and you only drink water, not doing a lot of eating, what you do is wash your salt out. And that electrolyte imbalance has another effect in the body, and you feel logy and tired, and you start to think in what I call it slow motion. You know, so that's, I think that's the point that Dr. Switzer's making with the U curve. Everything, you know, activity, sleep, food, there is a medium point that overdoing or underdoing have their own set of consequences.
Julie? Yeah.
A question about the inflammation, because I find that very interesting when you guys talk about that. So can you expand on that a little bit more? Because I do have inflammation in my tendons and things that occur that, and I exercise a lot and stuff, but still it's very interesting that you brought that up. So could you expand on that? I mean, is it in the cells that you're talking about inflammation, or I mean, what is it when you're saying inflammation?
So the question is about the role of inflammation, Dr. Switzer.
So this is a very interesting topic. Again, I have to put it in perspective to say, where do we get this information? So one of my other specialties, it's on my card, or they introduced me as in liver cancer. So in people who have cirrhosis, so what cirrhosis is inflammation, or typically cirrhosis is caused by this chronic inflammation in the liver, causing the liver to get shrunk down and really irritated. People who have chronic cirrhosis and chronic inflammation in the liver have a higher risk of developing cancer. So people who have chronic hepatitis C, depending on everything else that's going on, they might have a 20% lifetime risk of developing liver cancer. But that means that 80% of people who have hepatitis C and the same conditions will never develop it. So what we do know is that, so that's one example. Another example is something called Barrett's esophagus. So where people have this chronic acid reflux causing chronic inflammation of their GI tract. We know that you, compared to the general population, have a higher risk of developing a cancer at that spot. But it's only a fraction of the people that have that. So not everybody with Barrett's esophagus. It's actually a very small fraction of people who get it, who get cancer. But what we found is that as we look back through scientific meetings and through all the research we're doing, people who have areas of chronic inflammation have an increased risk of developing malignancy where there's this chronic inflammation at. Now, you mentioned it because of joints, so don't stop exercising. Keep exercising. But I'm not aware, and I'll turn around to my colleagues. I'm not aware of any chronic inflammation of the tendons or joints, like muscle inflammation that's caused this. It's classically a cellular level of inflammation.
But I don't know if Joe is still in the room, the personal trainer that works with us, but for your joint inflammation, that's where the mistakes people make, they don't stretch before they, work out, run those kinds of things, that you have to warm it up. That will help with that.
And to kind of get to what Mary mentioned is for foods that increase inflammation. So we're kind of thinking backwards. We say, all right, if we know that people have chronic inflammation, are there areas where we can decrease that inflammation? And so the theory is that the hypothesis is by decreasing the foods that stimulate a cellular inflammation, will that translate into decreased cancer? The answer is we don't know, honestly. So it's not clear. We hope so, and that's why we make those recommendations, because we know that this chronic cellular inflammation predisposes you to getting genetic damage in the cell that messes up the DNA. But it's not quite clear. So again, it's kind of my general philosophy in life is moderation is the key. If you're having too much of any one thing, it's probably not good for you. And so try to be moderate in what you do. And so, maybe 10 years from now, we're going to look back and say, all this stuff we thought about, all this stuff was totally wrong. And that may be the case, but I think as long as we're doing it with the best intentions and the recommendations we as the medical profession share with you is wise recommendations, not extreme recommendations. That's the best advice I can give you.
Back on the inflammatory diet that Dr. Smith was talking about that I referred to, the bench scientists, what they did was assign an inflammatory scale to all these foods, but we don't, much like, when Dr. Greiner was talking about the mice and those kinds of things, so we have a number, or maybe those 50,000 genes that we don't know what they do. They now have to look and see what is the impact on the cell level. Is there one at all?
Sorry, I saw a hand, so let's do the hands.
With many cancers, I know there are predisposing factors, that kind of lead us down the path of getting that diagnosis. Have you found anything that has been a predisposing factor to appendix cancer?
So the question is, any factors that are a predisposition to appendix cancer?
Well, I get that question all the time, and the way I answer it is I wish there was, in a way, because then if we knew who was at risk for getting it, we could just easily take out their appendix. And I would love to have an elective appendectomy practice and be preventing cancer. Unfortunately, no, nothing that I know of. And, I have had people come into the clinic and say, I was a hairdresser all my life and exposed to chemicals. I got struck by lightning. I worked with depleted uranium. And there's just nothing that anybody has put a finger on. Again, it is so rare. And yet you will hear stories, remarkable stories, some that we were sharing, and others that I've heard from patients that, they develop this appendix cancer and then they find out that somebody 2 blocks over in their neighborhood also was diagnosed with it. And then you start to wonder, well, is there something that's driving it? One thing that we do know, and we looked at this ourselves, our incidence of appendix cancer is much higher than we ever thought it was. We published a paper a couple years ago where we looked at the number of appendixes that we removed for acute appendicitis here, and we looked at how many of them had cancers in them, and it was a remarkable 3%. So, the numbers that are quoted are 1 in a million, and we had 3% of the appendixes that we took out had tumors. And for people who presented with a perforated appendix, and because it was already perforated, the surgeons elected to wait and then take it out 6 or 8 weeks later, called an interval appendectomy, the incidence was actually 30% in patients between 35 and 70 years old. And so within the general surgery community, there's a big debate about, oh, if the person comes in with a perforated appendicitis and you can avoid an operation and just put them on antibiotics and they get over it, then that's all you need to do, because the risk of recurrent appendicitis is only 16%. And if they have that, then we'll take out their appendix at that time. So we published our data and encouraged people, even if you have a perforated appendicitis and you're managing it with antibiotics and non-surgically at first, take it out at 6 to 8 weeks. Ours was the second paper, actually, that was published by another group out in Arizona. So a completely, totally different environment than, I was thinking, well, maybe it's the Blackstone Valley and all the, industry that we've had here, but this was in the desert Southwest, and they had almost identical numbers. So I think the incidence is really higher. I think it's probably higher. It's higher across the board. It would be very interesting to do a study where we did compare, a Worcester to a desert Southwest to a Dartmouth, New Hampshire to a urban, downtown New York or Chicago or something like that, and see if it really is different. But and as I tell everybody, I think everybody in the room is probably aware, it does not run in families either, and so it's an important question that everybody asks. But their children and their brothers and sisters don't need to get their appendix taken out prophylactically. There's absolutely no increased risk. They have the same risk that you had, or that anybody has of getting it. So again, I wish there was a way of predicting it. So it would be an easy one to take care of, yeah. Because who needs it, right? We don't even need it.
The question I have is, my father-in-law had appendix cancer a year and a half ago, and he had the surgery, the whole 9 yards, he's doing amazing. But a week ago, he had to have his gallbladder taken out because it became gangrenous. Now, is that related? Could that have been related in some way?
So the question is whether a gangrenous gallbladder in an appendix cancer patient is related.
So I wonder if maybe it had something to do with the damage or from having the cancer. I mean, obviously they've checked him. They're still saying that everything was clear because they removed a good chunk of his colon as well at the time of the surgery.
I'm glad to hear that he's doing well. And they did well with his gallbladder surgery?
Yes, he did.
Okay, good, excellent. So problems with the gallbladder are pretty common. They happen to most people that they happen to don't have cancer. One thing that we certainly can see, and anybody who's been through the HIPEC or knows somebody who's been through the HIPEC, everybody loses a lot of weight after that surgery, right? And so when people lose a lot of weight rapidly like that is when they can form gallstones. And so it may have, and that is usually the most common cause of a problem with the gallbladder, even a gangrenous gallbladder. So you get a gallstone that's impacted, the gallbladder gets inflamed, inflammation again, infected, and then it basically it dies. I mean, basically, a gangrenous gallbladder is really a dead gallbladder. It can make a person very sick, and so I've not seen it happen to the point where I think it's related to the HIPEC or the chemotherapy, but I could definitely put together a story of if he lost a lot of weight and he formed some gallstones and then he got acute cholecystitis and the gallbladder got inflamed and infected and then very sick and he had to have it taken out. So I can imagine that, and we're actually starting to recognize that as happening relatively frequently after HIPEC, and one of the last things you want to do after a HIPEC is go back and take out somebody's gallbladder, because you can't, ideally we would take them out through the laparoscope and the cameras and the small incisions, but a lot of times after the HIPEC with the scar formation, you can't get back in laparoscopically, so now you have to do an open gallbladder, and then people are in the hospital for a week. I mean, it's much longer. So a lot of surgeons are actually electing to just take out the gallbladder at the time of the HIPEC to avoid the whole problem. Normally what we do is, we don't want to do any more surgery than we absolutely have to. So we usually only take out what is involved with the tumor. We always feel the gallbladder, and if there are gallstones in it, we will take it out to avoid this problem. But routinely, people haven't been taking out the gallbladder unless there's tumor on it, stones in it. But some surgeons are starting to say, I don't want to have to be back here to take out the gallbladder, so I'm just going to take it out. Yeah, and so it's, I don't know exactly, that would actually be another interesting study if you could look at the numbers and find out, is it worth it, and should we be recommending that everybody take out the gallbladder prophylactically at HIPEC? It's a good question, yeah.
So the question is contraindications to a second HIPEC.
So that depends on the type of tumor, but if we're talking about appendix cancer, the contraindications are really the same as to a first HIPEC. So first of all, the person has to be strong enough to go through it. And so at that point, somebody may have had a lot of treatments, a lot of chemotherapy, and their tumor has recurred. So it kind of depends on how well they're doing. Are they physically able to go through it? The second thing is the histology of their original tumor. How quickly did it come back from the time of the last HIPEC? So there's a general recommendation that we really, most of the time we avoid trying to do HIPECs within the first 2 years after a first HIPEC. So if somebody recurs very quickly after their first HIPEC, that tumor is telling us something about its biology, and to try to go back in and do another one 3 or 6 months after the first one, it's probably not going to be helpful. But if a person recurs 2 years later, 3 years later, 5 years later, and it's, you know, and then the next step is, okay, if it makes sense from a biology standpoint, now looking at the CAT scan or the MRI, does it look like we can get all the tumor out? And if the answer to that is yes, and the person is strong enough, then that's it. So those would, the contraindications would be kind of the same. The fitness of the person, whether or not all the tumor can be removed, and now with this added information about how the tumor's behaving, does it make sense from an oncologic or cancer standpoint? So. Yes, absolutely.
I just want to add to that, because I had my first HIPEC, and then I recurred and had my second HIPEC more or less a year to the day of my first one. And I think exactly what you were saying, the surgeons looked at all the different aspects, not just let's go back in there. They looked at my, you know, my strength physically, whether they could get all of the disease out, whether they thought it would be of benefit to me. And then I went on to have a third HIPEC 15 months after the second one. So again, all of those sort of different factors were taken into account, not just, you know, from a surgical aspect. It was sort of talking to me too as a patient and what my aspirations were, I guess.
My husband's was also a year to the day almost from his first. His second was. And I think part of it, and I'm sure Laura can speak to this, but sometimes it depends on certain individual factors in the patient. In my husband's case, his doctor was Dr. Sardi. He did a complete cytoreduction. He said it was a textbook case. It went perfectly, and he couldn't believe how fast it came back and how much it came back. And he had a theory that my husband just didn't respond to the drug that they used. And he said, if I use a different drug, I really think I'll have a better response because I was able to get out the tumor. I think I can get it again. But it was growing so fast, he wanted to really get in there and try it. And my husband was in very good health and recovered very quickly from the first one. So in his case, it worked out well. The second drug worked amazingly well. And it kind of proved the theory that was why the first one didn't work. So, but we also did some assays and some testing on the chemos to kind of see if it fared, and it did. It did actually show that the first drug he wasn't very responsive to, and the second one he was. So we had all that information when we came up with the theory. So, and we had spoken to some other doctors that said the 2-year rule of thumb, but we pulled all this information together and thought it was a good enough case to go ahead and do it. So.
Yeah, that 2 years is really what Carolyn just said. It's a rule of thumb, but you tailor it to the individual circumstances, absolutely. Mm-hmm.
So the question is, can tumor biology change, or are your genes your genes?
So that's an excellent question. And so I did not take the time because I was already running over earlier. So genes, we all have 23 chromosomes that come from our mother and from our father, and those are our internal roadmaps. Now, those are how those are supposed to be working. It's the map to tell the cells exactly what it's supposed to do, and so those don't change. But what happens is that over time, due to possibly inflammation, possibly diet, possibly some factors we don't even know classically what happens is that you get a mutation. It makes the cancer kind of, let's say, it makes it not work appropriately. The proteins that the gene codes for isn't working appropriately. And then what classically happens is that because a lot of these proteins are involved in the regulatory mechanism of telling the cell to grow or stop or so forth, what classically ends up happening as it grows and divides, it actually it's dividing quicker without the natural checks and balances. It classically picks up more mutations and then more mutations. And so over time, your internal genes don't change, your human genes don't change, but the tumor genes, they tend to, as they grow, they get angrier and angrier and angrier. So I kind of think about, I like the analogy of fidelity. So I think about, like, if you take a photocopy of, anything, you take our program and you photocopy it on a copy machine, and if you photocopy the first copy, it comes out pretty good. But if you photocopy the copy, it comes a little grainier, and then you photocopy a copy of the copy, it's more grainier. And if you keep photocopying copies of copies of copies, 10 generations down the road, you can't even tell what it started off as. And so that's what ends up happening with the genes in a tumor, is that the longer you have the tumor, the more likely the genetic copy is going to be more flawed. And so as the longer you have tumors, it tends to be that you have more genetic abnormalities, which lead it to be more aggressive, and more and more proteins are affected. And that's actually one of the things that I always talk about to my patients that are here, that stands out about appendix cancer. One of the reasons why you say, well, the appendix is just a little appendage on the edge of the colon. It's exactly the same tissue. Why is appendix cancer, people can live 12, 16 years with appendix cancer, but if you got stage 4 colon cancer, it's much, much shorter. And I suspect, my scientific mind kicks in, I suspect it is that the nature of the appendix is that it's this small fusiform organ, that it's much more likely to rupture outside of the organ earlier in the course, when you're still at the first copy, not when you're at the 100th copy. So you have less mutations affected. And so I think that scientifically, I think that it behaves differently, just because it tends to spread to the peritoneum or around the belly sooner in the course of the disease.
I just want to add again about the supplements in this setting, that's part of the folate story, that the APC gene, which is one of the ones that's implicated in polyps and colon cancer, needs folate. When they found that there was an issue with deficiency, and so that's where a lot of the folate supplementation came out of, and as Americans, that was why they fortified, part of the reason they fortified cereal. Some of that was for children, but so then we get into the opposite of using excess, but that's an example of when the gene kind of turns on and the wrong stuff happens.
So if it comes back then a second time, is it likely to be a more difficult version?
So the question is if it comes back, does it tend to be more aggressive or a more different version? And the answer is, it's not clear. It maybe not. We're at large centers that see a lot of this. We're talking about series where, so I can quote you a study with colon cancer with 4,000 patients in the study. The largest series that I'm aware of is from MD Anderson, and it's under 300 patients. So I can't, with the same amount of conviction or with the same amount of confidence, I can't say yes or no. What I can tell you is that institutionally here we've seen over 160 patients in the past 3 or 4 years, and what I can say is that we've seen it both ways. So it doesn't have to be that way. It doesn't have to be when it comes back it's more aggressive. We've seen it be more aggressive when it comes back. We've also seen it come back the same as it was.
Do you ever see it come back less aggressive?
Actually, we have, well, in a way, I have seen that. So I have seen a person with signet ring cell who was treated with systemic chemotherapy, and then when it came back and we went to HIPEC, it was actually the low-grade stuff that was all that was left. So I've seen that in that sense. And I think, in my mind, what I think is that the systemic chemotherapy treated the signet ring cells and didn't treat the more slowly dividing cells that are less sensitive to chemotherapy, and so that was what was left behind. We have definitely seen people who have the low grade, the DPAM or however we want to call it, do very well, and then when it comes back as the higher grade tumor. But that's the exception more than the rule. So most people, when it comes back as the same grade or type that it was originally. So and that's how it looks under the microscope. Now, the interesting thing would be to say, okay, here was your tumor 5 years earlier, here's your tumor now. They look the same under the microscope. Has there been this shift at the DNA level? You know, are the different genes that are now mutated and upregulated and downregulated? That, you know, we don't know the answer to that question.
Go ahead.
If in your husband's case, different chemos work differently, why don't institutions just check before they just, if you're going to do this big surgery?
The question is, if different chemos work differently for different people, why don't institutions check and see which chemos will work best before they do the surgery?
So that is, so for a medical oncologist that I give chemotherapy for a living, that's kind of the holy grail of what I would love to do. I'd say is that is, there's not a great way to test for that. And hopefully, with the avatar model, that you will get your tumor in a mouse, and we will be able to check your tumor, how it responds, that will be a reality. As of yet, it's not. So right now, if you get diagnosed with cancer, then we're going to be able to grow it. But we're usually, by the time there's enough mice for us to challenge in different areas, you've already gone through 1 or 2 different treatment options. So it's something that not just us, but many large academic centers are striving to be able to predict how well people are going to respond to this. And so for now, within oncology, we're kind of chasing our tails a little bit. What we know is that on average, most people respond. So this is how we treat by statistics, but that 80% response rates. So this is why we treat most people with this regimen, because most people respond to it. But as of yet, we don't have a real-time way to predict this. There's a lot of research going on in this field in that area, not just in appendix cancer, but in any tumors.
And there are some commercially available testing where you can have your tumor sent and they can test it and see what type of chemotherapy it responds to. I can tell you we are really good at killing cancer cells in a petri dish. And so we can get that information. What we usually find is that the cancer cells are responsive to the chemotherapies that we were going to give anyways, in the lab. And then if not, even though they may be responsive in the lab, when we give the chemotherapy to people, it may not work. And there's a whole other area of research going on in what we call the host environment and how the chemotherapy works within an individual person within the area where the tumor is located. For example, pancreas cancer, one of the reasons why it is so difficult to treat is that these cancer cells tend to be scant, but they are in this dense fibrotic stroma of tissue. It's almost like scar tissue, and so the chemotherapy just can't get there. It may be effective, but if it can't get there, it's not going to kill the cancer cells. So there's that whole other component of treating with chemotherapy and why it doesn't work sometimes. So yeah, but that would be the best thing. It would be like, if we could just take a person's tumor and test it and then say, this is the HIPEC chemotherapy that you need. I would love that.
We had the assay done, but it did not make the decision for us. I mean, the decision was made based on Dr. Sardi's 15 years of experience saying the recurrence shouldn't have happened like this. And then the assay kind of backed up his already very well thought out theory, which, just kind of, it was more evidence. But that wasn't what guided the decision. The decision was based on clinical experience and judgment more than anything.
I will say this is not a new concept. This is something that they've been trying. We as the medical profession have been trying for almost 20 years. So, for example, there is an association with a gene, whether or not you're responsive to platinum medications, and there's this association. So we can test for this gene. Interestingly enough, when we did this in a large randomized fashion, whether or not, and we can say again in a petri dish that this is going to work or it's not going to work. But when we tried to use that association with that gene in a large randomized fashion, it didn't work. It didn't make a difference whether or not you had this gene or not. You still responded or didn't. So I'd say is that there's lots of very fascinating, interesting things going on in this area, but it's not real time yet, if that makes sense.
So I have a question probably for Dr. Lambert, for all of you. And we've talked about this last night, so you probably knew this was coming, but when does appendix cancer become PMP? Because when Jerry was diagnosed, we were told he had PMP. It was an obvious case. He had a tumor full of mucin and a stomach full of mucin and tumor. But as we've met a lot of patients over the years, we have met people who probably have identical cases. One told PMP, one told just appendix cancer. And anywhere from people with adenocarcinoma or higher grade are told no PMP, and some people are told they are. Some people with a limited amount of spread throughout the abdomen are told no PMP. Some people are told they are. So who has PMP, I guess is the question. I mean, what is it in your mind? And I know there's been a lot of debate about this, and it's kind of an offshoot of Dr. Misdraji's presentation.
Where is Dr. Misdraji?
Sorry. I should have asked when he was here.
So no, but that is that. So that's actually one thing that did come out of the consensus, and he didn't talk about that. Is that pseudomyxoma peritoni is a description of mucinous fluid in the abdomen. That's all it is. That's all it is. It's mucinous fluid in the abdomen. It can come from any source. It can come from the appendix. It can come from the ovary. It can come from the stomach. It can come from the colon. Very rare. The vast majority of PMP comes from the appendix. Very rarely does it come from those other sources, but it can. And that is, in my mind, that is all that it is. And then the next most important thing is what he did mention is that the most important thing in terms of how are we going to expect this tumor to behave and how should we treat the person depends on what does the tumor cells look like in that mucinous fluid. That's the most important question. Are there cells in there, and if so, what do they look like? Are they the low grade or are they the high grade? And then from there, that's how we decide.
But you say even a tiny bit of fluid, it doesn't matter how much.
It's not the volume, it's the character of it. So a watery fluid in the abdomen that just looks like water is ascites. That's what we would call that, ascites fluid. That can come from tumors, it can come from liver failure, it can come from infection. That's ascites. If it's gelatinous, mucinous, that stuff that I showed in that picture, that's PMP. That's pseudomyxoma. It's mucinous fluid in the abdomen.
Yeah, because there are a lot of people who have that condition who are told they do not have PMP. Very confusing.
So to kind of take it back to, since I asked me to talk about this, to a molecular level, in a sense that, essentially it's the same cancer, but it's whether or not a certain gene was turned on to make that mucinous fluid, that gelatinous, that jelly material. And so we're kind of in the weeds a little bit, in a sense that, even although this is the PMP Foundation, but PMP is just a description of what they see when they look at the jelly material. And whether or not you get that jelly material from appendix cancer or from another cancer, it means that gene that's turned on to make that jelly.